Good morning, everybody. Again, my name's Hugh Brewster. I'm the Executive Director of Transforming Faces in Toronto, Canada, and I'm hosting today's Circle of Cleft Professionals webinar, our 13th in just over a year, and we're delighted that you've joined us. And today we'll be talking a little bit more about bringing an ethics lens to rehabilitation in the era of COVID-19, which I think probably all of us are thinking about every single day right now in this period of great uncertainty. Just a quick reminder, I think we've probably all had a chance to explore Zoom a little bit more than just the Circle of Cleft Professionals. And if this is your first time, a couple of quick reminders. Please let us know your first and last name, just so we can know around the world who we're speaking with. We'll keep you on mute until we get to our question and answer time. It'd be great to have you ask your questions yourself, but also you can use the chat feature. And if you haven't used the chat feature before, I mean, if you click on chat that comes up on your screen, you can move that box around. It can be wherever you want it on the screen, so you can monitor and not miss any of the conversation or the questions that are coming around. We'll invite you at the end if you'd like to activate your video to be able to ask a question directly to Dr. Hunt. We'd be delighted. So we'll get to that in about 25 minutes. So what are we doing today? We'll give you a quick update on the Circle of Cleft Professionals. We'll have Dr. Matthew Hunt's presentation and then discussion. And we are increasing the frequency of these webinars in this time when there is so much to learn and to discuss as we wait, or as we push, or as we hope for the easing of restrictions in terms of COVID-19. So we have an exciting webinar coming up shortly on measuring cleft-related quality of life, which could be a really important part of your argument to your hospital, to your Ministry of Health, to your own team in thinking about what is the value of really leaning into cleft care for a country? How does this move forward? And so one lens we haven't thought about on this platform before is the economic impact of cleft care. So Dr. Karen Chung has been working on a PhD on that topic, and she'll share some of her research findings on May 14th. And stay tuned, we've got some other webinars coming up at the end of the month and more in June. So lots happening in the Circle of Cleft Professionals, and we're delighted to invite you to participate. So if this is your first time, welcome. Again, quickly, our objectives in joining together like this are to facilitate collaboration, to communicate impact, and to support the growth of comprehensive cleft care. And we're interested in people implementing comprehensive cleft care in resource-constrained countries or contexts. So all of us have an interest in that, and that's really what we'll be thinking about today as we talk about ethics. So a quick reminder, we're up to 167 members, 15 specialties in 33 countries. Many speech therapists on this call, as well as surgeons on this call, and that's reflective in overall who our members are. We don't want to forget the orthodontists as well, and we had a wonderful webinar just a couple weeks ago on pre-surgical orthodontics, pre-surgical care, and again, that has application as CCC proponents. We know that team-based multidisciplinary care is the way to go. So having a really good sense of what every other specialty is working on helps us provide better care to patients overall. So you'll see a little bit of of where people are calling in from today and where our members are. You can see there are also some gaps. And so if you know professionals, if you have some connections and professionals in places like Australia or Eastern Europe or Russia, that would help to fill out our map. And we're always looking for new members. So please do spread the word. Again, we're grateful to our charity supporters, all 10, who have an NGO connection, who are really proposing topics and supporting our work and proposing, who should be involved in this. And so many of you have had an invitation from one of these sponsors, which we're grateful for. But without further ado, webinar number 13, Bringing an Ethics Lens to Rehabilitation in the Era of COVID-19 with Dr. Matthew Hunt from McGill University, which is a very prominent university in Canada in the province of Quebec, in the city of Montreal. And Dr. Hunt's an associate professor and the director of research at the School of Physical and Occupational Therapy at McGill University, Canada. I think he'll share, but his initial work as a professional was as a physiotherapist, and he's obviously continued to broaden his horizons from there. He conducts research at the intersection of ethics, rehabilitation, and global health, and he co-leads the Humanitarian Health Ethics Research Group, and you can see the website there. So we're delighted to have Dr. Hunt with us, and now we'll do that magic of Zoom where I will stop sharing my screen, Dr. Hunt will start sharing his screen, and then we'll give the floor over to you, Montreal.
Thank you very much.
It's working. Well done.
Hey, the webinar is already a success. We've managed to do the handover on Zoom with the share slides. We had a bit of challenge with that earlier. I just want to start by expressing my gratitude for the invitation to come and join you this morning. As Hugh mentioned, I'm a physiotherapist by training and have moved into the area of ethics, often with a focus on two domains. One is on ethics and rehabilitation, not exclusively in the area of physiotherapy, but more broadly rehabilitation. And the other is thinking about global health. So I do a lot of work also in that bio from Hugh is around humanitarian action and global health action in relation to ethics. And so hopefully this conversation and your domain of practice can allow for some convergence between those interests. So I'm going to spend the next, the next period of time trying to draw some of these connections together. My idea of taking up an ethics lens for you is really thinking about how values can guide actions and what that might mean in the context of COVID-19. Yeah, we'll see where it takes us. I do hope that it's helpful, valuable, and also acknowledging that I'm not fully aware of all the context of the domain of practice that you inhabit. So there might be things also afterwards that I would invite, links to be made or people to reflect on other aspects of relevance of this topic to the particular context of work that you do. When I'm thinking about rehabilitation, I'm using that, there's a distinction that's often made between health strategies. So rehabilitation as a health strategy in distinction from curative or preventive or supportive care or health strategies. Rehabilitation really focusing on trying to optimize, to restore, to maintain function for people who have health conditions that lead to disability, might lead to disability, and very much in the context of the environment in which people are living. So that's the lens that I bring to rehabilitation, or the way that I'm thinking about rehabilitation here, and just to acknowledge that you might be thinking about it in a slightly different way. The second parameter I wanted to offer at the start was also to acknowledge diversity. It's something that came up in Hugh's introduction. People maybe on this call, but certainly in your network, are from 33 different countries. He was referring to different contexts now in the setting of COVID. There are different, we're at different phases of the pandemic. People are living in different contexts of restrictions, for example, confinement, deconfinement, ramping up of care in different contexts. So one challenge for this conversation is that we're probably all in very different places. I was hearing yesterday about the difference between Tanzania and Rwanda, neighboring countries with a lot of trade between them, Rwanda having taken a very restrictive approach in terms of public health measures and Tanzania not. So you have two neighboring countries living out the COVID situation quite differently in terms of the public health response. And obviously the impacts that that has on clinical care and on healthcare generally, on rehabilitation. So this issue of diversity is the next thing I wanted to acknowledge, different timelines. And then the third point here about reflection and dialogue is just to really acknowledge what is my goal. So that's what I'm aiming to encourage, support through the presentation. My goal is to get us thinking a little bit and get us talking a little bit, using an ethics perspective or bringing an ethics perspective to the work that we're doing, to our responsibilities in this context. So the presentation will really be in two parts. The first part will be about ethics and COVID-19 in a more general way, and then in the second half try and drill down more specifically to think about rehabilitation. So the first observation that I would make is that it's really interesting to see, I guess in a variety of contexts, how the situation of crisis, of insecurity, I think is making people very conscious of their responsibilities towards others. And it's been described that the heart of ethics is other-mindedness. So maybe a distilling down of ethics being this orientation towards responsibilities for others. And I think this is something that, by and large is being activated and acted upon by many people in the current context. So ethical concerns being at the forefront of our daily lives in ways that we don't usually think about. This is on the right is a cartoon of representing the Chief Public Health Officer of Canada, and sort of a take on all the models that we're seeing, the different epidemiological curves, and the suggestion that actually one of the things that we're seeing perhaps at the very local level is a response of people being other-minded or being good to one another. And so we get this, this sense, and I think this is part of a lot of conversations right now, is that we are called to be responsive to the needs of others in our everyday lives. And at the same time, what's very clear as well is that beyond the interactive, sort of neighborly context, we're also faced as professionals, as institutions, as societies, with a range of ethical questions that need to be asked and answered. These are questions that are fundamentally about ethics, or that have an ethical dimension. As people who are involved in healthcare, you're facing this in your clinical work. Maybe as people who lead organizations related to Cleft Care, there are ethical questions about how we respond in a situation of crisis, how you might allocate resources, how you might make decisions. But we're seeing this on a range of levels. And one of the challenges, one thing is to acknowledge that we have these ethical questions, and the next is like, how can we respond, or what are the tools that ethics can also bring, as well as sort of diagnosing something as being an ethical concern, but how can ethics help us actually to orient and respond? So we'll try and get onto some of that. Other-mindedness is what I suggested as the heart of ethics. A more fulsome definition comes from the philosopher Paul Ricard. I'll say it in French because it was originally in French, but he said that the visée de l'éthique est la vie bonne avec et pour autrui dans des institutions justes. The aim of ethics is the good life with and for others in just institutions. Now, lots of definitions about ethics. I particularly like this one. One of the reasons is that it describes ethics as aspirational. And so it's couched in these terms of something we aim for. The aim of ethics is the good life. And the good life is something that we're going to conceive of differently, depending on how we're situated and what we think is important. But there's this conception that we are aiming for a conception of the good, even in a situation of crisis. How do we conceive of the good right now for each other? And the second part of the definition is about relationships with and for others. And then the third really emphasizes the institutions. And this might be a healthcare institution, or it might be other societal institutions. It could be the organizations that you are involved in. How are they manifesting justice or fairness? So the way in which our relationships take place, the conception or the possibility of the good life, is often structured in the context of justice and institutions. So these aspects can be helpful in terms of layering in some additional aspects of ethics. I think one of the most interesting writers and thinkers in the area of humanitarian ethics is somebody named Hugo Slim. And he's just left a position as the chief policy advisor for the International Committee of the Red Cross. And he's spoken about emergency ethics in the context of COVID-19, thinking about what can we learn from the context of humanitarian ethics and think about that now at this more globalized level. And so I have a quotation from him here, thinking about hard choices, which might be true, the importance of balancing rights and duties, and the importance of virtues. And he really emphasized 4 lessons, sort of 4 takeaway things from this concept of emergency ethics. And the first is that notion that, you know, we may focus on rights, but we also, as well as human rights, maybe we should be thinking also about our human duties, what we're called to in a context of crisis in terms of response for all of us. His second point that he makes is just how central leadership and ethical leadership, leaders with integrity, is in the situation of emergency. That emergency ethics calls for virtuous action. So virtues being these character traits, these dispositions, these orientations to how we respond. And he described several here: kindness, humanity, courage. I liked a description that he offered, that the front line of the pandemic doesn't just run all around us, but runs through each one of us. And then the fourth observation is that the situation of the pandemic, the burdens, the responsibilities don't fall equally. And so we need to be particularly attentive to issues of equity and issues of vulnerability in the context of COVID-19. So there is, or there has been, talk about the pandemic as an equalizer. So thinking about the pandemic as something that affects everyone and sort of as an equalizer. And what's becoming very clear is that that is not the case. So as Hugo Slim is pointing to, we need to think particularly about marginalization. Yes, the pandemic might affect princes and prime ministers and celebrities, but rather than being an equalizer, it seems to be an aggravator of inequality. So the other aspects that we need to be particularly honing in on are the ways in which people who are in positions of vulnerability or in marginalized positions, we might see this differential impact and a particular need to respond to those people's circumstances and situation. So we could see a variety of differences. One thing that people might distinguish is between inequality and inequity. Inequality might be described as a description of unequal effects. So mortality increasing with age. In the context of COVID-19, inequity involves an ethical assessment. It says something about fairness and justice. So in the Canadian context, I live in Montreal, which is the city most affected in Canada by COVID-19, where we're seeing the vast majority of deaths from COVID-19 being older people living in old age homes, in residencies, nursing homes, those being the situations in which deaths are occurring, and lots of questions about understaffing and under-equipping. And so we could frame that perhaps in the context of an inequity. At the global level, so if we think about the difference between inequality and inequity, we see all sorts of questions that might arise in relation to inequity. So how are public health measures applicable? How can people protect themselves in a context where, for example, water and sanitation might be less available, where there isn't a safety social nets, where people might rely on informal economies? Imagine migrant workers living in a dormitory or people in a refugee camp. How can they take social distancing measures in crowded circumstances? And then a very profound situation of inequity can arise too in the way in which there's massive competition in the current moment. We tend to nationalize our focus or localize our focus to a certain degree in the context of crisis and thinking about borders from a public health perspective. But one of the concerns, for example, on access to PPE has been huge competition. So people are being outpriced and outcompeted, and some countries are not able to access PPE, partly because they just can't compete on the global scale. And we hear all sorts of crazy stories about efforts to access PPE, and understandably so. But it does raise these questions about inequality or inequity. And if we think about other-mindedness, that discussion or that consideration of inequity at the global scale, and I think maybe particularly because this is such a global group and your focus is at that international level, I just want to acknowledge questions about common good and solidarity. So how do we think about responsibility, or, well, maybe I can phrase it this way. I think that, in this moment, there's a tendency to be very local in our focus often. I have to say I've never focused more on my local city newspaper than I have in the current moment, and the tendency to focus on what's happening all right around us. And one of the things I appreciate about the group and your effort to continue your Cleft Circle to bring people in from places all over the world is this greater awareness or attentiveness to issues of broader solidarity or broader common good considerations, that we are in very profound ways all in this together. The nature of this sort of public health crisis is one that it's global and universal. And how can we think about sort of pragmatic acts of solidarity? So, tangibly, I don't know how you would see that in your individual circumstances or in your organizations, but there might be opportunities for that sort of reaching out and sharing. The example of the personal protective equipment might be one where you have situations where there are contexts where there's more supply and less need, and the opportunity to share that with places with less supply and more need. But thinking about what does common good and pragmatic solidarity look for us. And I've kept it fairly broad in that initial overview of some of the context of COVID and ethics. And it's important to acknowledge that there are all sorts of fine-grained questions that come up, right? Like people are asking about the ethics of using apps for contact tracing, or they're asking questions about the justification or how we balance out the restrictiveness of public health measures. There are questions about research in this current context and what does that mean for research ethics. So we could have a conversation or webinars that focus on any of these particular situations. So I'll just acknowledge that there is this host of ethical, domains of ethical inquiry. But in the second half of the presentation, what I want to do is focus on these ethical considerations for rehabilitation, care programs, and organizations, because that's our shared concern for today. And in a sense, those are, it's the sort of sort of context of care where we haven't been having the conversations, I think, as much about ethical considerations, like the neon light questions, the burning and pressing questions about triage or resource allocation or these other issues that I've mentioned. It makes sense that that's where the focus has been at a broad level. And yet we have this responsibility to think carefully, if this is our domain of practice, what then about the ethics of the work that we do and the practice that we have? So I'll turn on to this question now. I'm going to suggest a few thoughts that might be more for situations where things are more restricted and in a phase where we might be ramping up care, and it sounds like some people on the call might be experiencing that. And then I'll finish with 3 related thoughts that might also sort of give us some paths forward in terms of different ways of acting. So here we go. The first thing that I would like to do is I actually ask you a question, and it would be something for you to reflect upon. If we're thinking about ethical considerations or reference points for the work that you do, whether, the type of practice that you're doing. I know that some people are speech language pathologists, others are surgeons, other people are involved in administration or leadership roles in organizations. Maybe they're orthodontists, dentists, and others. So we have different domains of practice, so maybe we have different sets of responsibilities in this context. But for each of us, a starting place in thinking about the ethics of our work might be to consider how we get our ethical bearings, or what are our ethical reference points. So are there things that you could articulate? It might be at the level of your organization. You know, Hugh Brewster could be thinking about the organization and the organization he leads. What are the values and the mission and the identity? What are you aiming to achieve? What are your goals and obligations? And each one of you, you might have professional reference points that help guide or think about your ethics. You might have personal ones, you might have organizational ones. And my encouragement is that we would start there. And these are the things that we may have to return to, maybe even more consciously or deliberately in a situation where we are in extremis, where we are pushed by a situation that is particularly difficult. And if we think about those reference points, I want to describe this as a dynamic between sort of like in the context of rehabilitation programming amidst public health response, where there are two really important poles or elements in this conversation. One is very clearly, given the public health imperatives, is of minimizing harm. What are the actions that are necessary? Some of these are required by public health authorities in relation to minimizing the potential for harms of patients, of staff, of population. What are the efforts that we need to make? And it could be, and I think this is really important for us to think about it from a rehabilitation perspective, the risks of harm that might come with propagating the virus, the risks of harm that might also come in association with different, like with delayed treatments, with different approaches to adapt our model of treatments. So there are these concerns about harm and thinking about harm, and at the same time acknowledging what is our primary goal in rehabilitation. I mentioned it at the beginning, this idea of optimizing function for people experiencing or likely to experience disability in the context of the environments in which they inhabit. How can we aim to achieve best outcomes for people in the context of a public health response? And also really being focused too on upholding people's dignity, treating people with respect. And that might be challenged by the types of things that keep us at a physical distance, that might challenge communication. It's a very noisy space where lots of information is being shared. How do we ensure these messages that we are listening to people and trying to be responsive to them? I would like to share 4 elements that we may think of from a programming perspective. And to do this, I'm going to draw on different notions. One of them is a concept of procedural fairness. So how we think about what we ought to do in terms of what processes will be fair, even acknowledging the limitations of the current moment. So on the left is this notion of proportional. And from an ethics perspective, where we're instituting efforts to limit the risks of harm, one of the important elements is to try and achieve a proportional response. So efforts to limit harm, such as restrictions on what care is possible, trying to achieve that proportionality so that you are making the limitations or placing the limitations such that they are the least restrictive possible but still effective. And so this is a key element of public health ethics that I think is relevant if you were organizing public health program or rehabilitation program in your particular context. The second would be a capacity for responsiveness. So how can, as you establish your plans to minimize harm and yet aim to achieve best outcomes, how can you be responsive to the circumstances as things evolve, but also, I think importantly, responsive to the people that you serve? How can you learn from what they're experiencing, listening to them, and using that feedback to make adjustments to the extent that's possible? You might also be listening to your partners if you're thinking about an international organization. listening to staff members. The third would be about transparency. So this is a key aspect of accountability, or at least, maybe it's better said, it is a prerequisite for accountability. And a key element of procedural fairness or procedural justice is to be transparent about the decisions that are being made and why. So if there are plans put in place that change the normal way of working that might limit access, for example, or delay treatment, are we being transparent about those reasons? And then fairness might come in too. One example would be about consistency. So if we establish new policies in the context of the crisis, are we applying them consistently, fairly, unless there are reasons to apply them differently for different people? Are we applying them consistently across the board? So these are some of the questions. And I'm going to use this model, which captures some of the elements that we might be thinking about. And I'm going to just offer a few reflections at two levels. One is sort of the current situation, a situation where we might be limiting or adjusting the care that's available or possible. And then I'll offer a few thoughts quickly about ramping up. So what's happening certainly in the context where I am, there's been a need to distinguish, a requirement to distinguish what is essential care in the rehabilitation context. And in terms of providing face-to-face care, really restricting that in terms of what is deemed essential care. It's interesting to note that that has also changed over time, that especially as we note from the perspective of trying to optimize function, but also prevent people losing function, that we've seen an increase in what we understand as essential rehabilitation care. And then how do we adapt care? For us, that's often been moving to sort of remote models. And I know that might be possible for some of the care that you provide, and in other instances, not possible at all. As we go remote, if that's a choice that's made, then there's some really important questions about follow-up and assessments, providing guidance to families on minimizing risks. There might be questions of the psychosocial support that can be provided to families as well. There are issues that might be more, sort of the first things we might think about: security of these platforms that we're using. Are we being consistent in terms of access to these resources? How do we maintain people's dignity? Even what are the issues of professional boundaries as we're doing sort of remote approaches to rehabilitation care? And overall, I'd say, are we being sufficiently transparent about the policies that we're making? Are we explaining? And so one part of responsiveness might be also offering these explanations about why something is considered essential care and what are the efforts to adapt. And then there might be a situation where care is delayed, and Hugh was referring to elective surgeries or surgeries being delayed, and that's clearly an instance where that is taking place. Many things in our domain of practice, yours and mine, will not be possible in terms of telehealth approaches and won't be deemed essential care. And so we end up with this situation of delayed care. And I'll mention that in a moment. But first, in this presentation, I'm going to share tools with you. And I'm going to ask your forbearance because I'm not going to explain them in any detail. I'm just going to offer them as places you could go. So this is a model that we created, which aims to help support people take a systematic approach when they're faced with an ethically challenging situation. It's nothing specific to a pandemic context, but it is specific to rehabilitation. And I can provide a copy and the full reference of this afterwards if you would like. But if you're looking for a micro level, so looking at particular contexts of care, particular decision making, this might be a tool that can help an individual or a team really think through more systematically about ethical dimensions of care and take a considered approach. So we'll share the reference to that later. And there'll be a second of these tools in a few minutes. PAHO has put out a document that may interest you about rehabilitation considerations during the COVID-19 outbreak. And I mentioned the idea of delay, and they put it quite simply here. There will inevitably be a backlog of rehabilitation needs that need to be addressed once containment measures begin to lift. And this is certainly the case. And I don't know to what extent, in your context, people are thinking about, well, how is that going to take place? The conversations that I've been a part of in my professional domain are largely around the biosafety considerations, about limiting contact, about keeping distance, about PPE and things of this nature. I think that there are some other questions that we could and should ask. With this backlog, are we really asking ourselves, well, whether there will be prioritization? How would we think through who, if we have this big backlog, whose care would be prioritized? People who have the greatest clinical need, maybe people who are in the most marginalized situations. One thing I wondered about is, should we be prioritizing the people who could not benefit from mitigation strategies? So if we had a telehealth approach, imagine people who don't have access to technology. So this is an equity concern, who couldn't benefit from a telehealth approach, even if it was available. Should they be prioritized in some way as we come back and we're facing this backlog? Again, we might think about consistency. There is a lot of literature, a lot of experience about waitlist management, thinking about how we deal with these issues. So this isn't something that we're going to face for the first time. So how could we use some of that knowledge about waitlist management that could help us as many people will be waiting to receive care that has been delayed? And as a general thought or a general observation, we've been doing a lot of effort. There's been a lot of effort to learn from other countries who are maybe ahead of us in this process. So overall, are there other places with innovative practices? Are there people who have tried things that we can learn from each other? And that might be another richness of this group, is sharing those experiences and the things that have been successful even in this next phase of ramping up or relaunching. So this was my second tool that I just want to quickly mention and that you could turn to if you're interested. It's a model called Accountability for Reasonableness. Maybe some of you know about it. And it's really focusing on situations of decision-making, maybe where you're setting priorities as an organization, for example, and setting out conditions that would provide an argument for an accountability for reasonableness. And there are really four parts. The first is, are we being clear about the rationale for our decisions? Are we referring to decisions that people will recognize as being relevant and important? Is there the possibility to adjust our approach or to revise it? And is there some oversight possibilities? And people have thought about accountability for reasonableness in the context of humanitarian non-governmental organizations. So I just referred to this, I think, really interesting article. They focused on Doctors Without Borders, Médecins Sans Frontières, and used this model to think about ethical decision-making at the organizational level. And you might be interested in turn to this, and I'll be happy to share this resource as well. So I'm going to finish by offering three concluding thoughts that go beyond sort of the program level, the care level, and three things that we might think about as rehabilitation professionals. How do we orient in terms of these three aspects: vulnerability, inclusion, and moral spaces? I was part of a group that contributed a commentary last week. We were responding to something written in the Lancet about being vulnerable in the context of COVID-19. And the point that we wanted to make is a distinction between being vulnerable and being made vulnerable. As rehabilitation professionals, this could be partly our lens of thinking about what does it mean to be made vulnerable in the era of COVID-19. From a rehabilitation perspective, focused on disability, one of the things we might be particularly attentive to is concerns about discrimination or stigma in relation to disability. On the left is a paper where they were thinking about discrimination in triage. And on the right is actually just sort of drawing attention in the context of Ontario and Canada to the ways in which government decisions weren't taking into account the needs of people with disabilities. And so from a rehabilitation perspective, how can we speak in to those situations in support? And I would ask you, what are the equivalents in the context specifically of Cleft? There's been in many places an across the board limitation on elective surgery, and that has obviously been necessary. Are there ways in which there are particular vulnerabilities, there's a particular timeliness, and are there concerns or considerations that you could draw to the foreground that might be necessary in this context? And I don't know the answer to that. I would just offer that as a reflection, as a community. How can you, or what are the ways in which you can draw attention to vulnerability for the communities that you serve? And that idea of vulnerability, I would draw towards the idea of attentiveness and inclusion. It's something that I mentioned before, but in this context, are we really are we listening to and being responsive to the experiences of the communities that we work with? So in your case, people and families affected by cleft palate, how are we sort of reaching out to them? If you're part of an international organization, how are you reaching out to and listening to the people that you work with, your global partners, other people in other places? Are there mechanisms for that to take place? And then this is the third point, and I want to suggest that there's this continuity of sort of tending to the vulnerability that people might experience. The second part being this desire to be attentive or listening. And then the third would be to make and maintain moral spaces. So I had two examples from physiotherapy where I see people making moral space. So space for exchange and dialogue across disciplines, organizations, and communities to talk about the ethical dimensions. And that's my open question for you. Can you as particular organizations, or even as a broader community, maybe as you talk about different things, how can you refer back and think about it from an ethics perspective as well? So with that, I'd like to thank you, and I really look forward to hearing your thoughts and reflections.
Thank you, Matthew. That was, yeah, really helpful for me personally in thinking through some of the contexts in which our partners face. I do want to make sure we have time to hear from everyone. So just a quick reminder, you can signal to me privately that you have a question by typing it into the chat box. You can raise your hand and activate your video. We'll keep a note. I mean, we do want to end on time, but I know there's lots to discuss here. So we'll be looking forward to hearing from the crew on the call. But I was just particularly interested in Dr. Hunt's three areas, thinking about vulnerability, thinking about inclusion, and thinking about moral spaces. And even before that, what occurred to me when you talked about transparency and fairness was, especially in the context where so many of our the families that our partners are supporting around the world, are coming from a vulnerable space in terms of economics. And so there's that suspicion, in terms of, is this care going to be offered for free? Is this going to be low cost? Can I afford this? And so as, that kind of welcome is being restricted necessarily by these government restrictions or restrictions at hospitals or, who can do what, how do we approach that idea of transparency and really leading to that, being clear about who is going to be prioritized for what kind of service as these restrictions are lifted? So I'll put that out there. We have our first question from Dr. Felicity Mehendale. She's the chair of the Cleft 2021 conference upcoming in Scotland. Do you want to read your question, Felicity, or do you want me to read it for you?
I'm fine. I've switched my mic on. So great. Thank you very much, Matthew. That was really, really interesting. I had a question, and it's around how best to manage the ethical risks when people take the approach, well, what I'm doing is better than what patients or families would have had anyway. And yes, that may mean something good is done, but it can, and I've seen it, result in unnecessary and unacceptable compromises in quality of care. So it's one, yeah, I don't know how, that's a really difficult area, I find.
Yes. Well, absolutely. Both, I think that's a hugely important question, probably at all times, but maybe it's nuanced in the current moment. And then secondly, I acknowledge that it's a hard one to think about. Let me say a few things. From a rehabilitation ethics perspective, I would say that questions about risk are probably the most common source of concern and discussion that I see happening. Like there's something fundamental about rehabilitation care that we're thinking about risk, maybe sometimes risky choices that patients want to make, risks associated with care. Like a lot of the rehabilitation approaches that we have, there is the potential for harm. You know, I'm a physiotherapist, right? You get someone up walking who's in a, like they need to walk to get better, but there also is the possibility of them falling, right? And yet there is this particular context too, where imagine the instance of like moving to a tele-rehabilitation approach where I can't properly assess the patient, or, you know, I'm trying to move forward with activities or exercises without really being able to finally appraise their ability to follow those exercises consistently, for example. So I think that's where professional judgment is going to be crucial. And I heard you say it, like some people are saying that they judge that, you know, they could do something safely, or it's better than not acting at all. And I think, how do we then support people to refine the professional judgment? Because it's going to be a judgment call sometimes. You know, is it the circumstance that we should be erring on the side of sort of being, you know, trying things or being innovative? Well, we probably need to innovate and try and find new solutions. But I think our index of sort of care and concern should also be very high. So we judge, we're critically appraising, is this really justified? Am I confident that we can do this in a way that won't harm people? Because ultimately, you know, the two sides that I described of minimizing harm and optimizing positive outcomes and treating people with respect, and, you know, acknowledging their autonomy and their capacity to choose. Those are the things we want to balance out. So I do really appreciate that concern. I just maybe will mention one last thing. One of the projects that we did around humanitarian ethics were issues around people acting at the edge of their, or like the boundaries of competency, which is the sort of thing that can happen more, I think, in humanitarian space or low resource context. And there are some comparable issues where we really need to be careful so that we don't just say, well, you know, the proper specialist isn't here, so I'm just going to do the best I can. We also have those similar sorts of concerns there too. Thank you.
Thank you, Felicity. Thank you, Matthew. Anyone else? As we wait, Matthew, oh, we might have another question coming in here. So the question coming from Bangalore. It's a very big issue to postpone elective cases like clefts, and hospitals are very clear that they want only emergencies done for now. And neither have the International Cleft Associations done anything to come out with new guidelines for cleft surgeries. So is this not an ethical problem that associations are sitting too silently, or not advocating? What would be the solution to this ethical moral angle, and what would be some of your suggestions to address it? So coming back to that idea of electiveness and what's critical in the midst of a pandemic. Thank you, Dr. Giant.
Yeah, excellent. And again, this is one of the really challenging questions, because, you know, okay, what do we need to be thinking about in this moment of pandemic, right? Largely we're talking about containing a virus, and we're talking about testing, tracing, treating, isolating is the square. And people have described that like, what's our focus right now is on the hot spots and that box. But there is an issue of blind spots too, right? So people have made this point very powerfully. People are facing famine and food insecurity. People are like primary care is at risk in many places. And there are questions of like, what'll be the long-term consequences from delaying, whether it's childhood vaccinations or different types of procedures, including absolutely Cleft Care. And so that's, a really challenging set of questions. And it's beyond my horizon of knowledge to know, like, how would you best judge where you would set that line? And it's going to be different in different places, and it's a moving target. So I just want to acknowledge how hard that is. And yet I think for sure there would be a place, like as Cleft professionals and organizations, you're well placed to speak to the question of like, what are the consequences? If that's a blind spot, what are the consequences of delay, and making sure that that's on the table. The example I had quickly, a newspaper article where they were identifying an issue that the government had declared non-essential, the office that was responsible for all the assistive devices. And it was I think it was just bureaucratic thinking, right? It was just a situation where they thought, that's not essential, we can close that office. And it needed people to say, well, for people with disabilities, to be able to process those applications for new assistive devices is essential. So sometimes it's also taking a stand from the perspective of saying, this is important and this is why it's important. And then that would go into the broader decision-making matrix, this wider horizon of thinking about what's justified in a particular context. So I don't have, so I think there's a place for for organizations, whatever level, associations, to be speaking to like, what are the consequences of delay? And then to try and be productive, good faith partners in those broader discussions of what's most important for societies right now. So thank you.
Thank you, Dr. Jayanth, Dr. Matthew. It's wonderful. Another question's come in, really honing in on the lens of respect and communicating respect and feeling understood. And that's interesting for cleft professionals who, especially with comprehensive cleft care, always working with a team-based approach. So that's both within teams as they start to figure out how to ramp up again, or how to extend care and hear each other and communicate that respect, but also then with families which you're working. I'm wondering if you could talk a little bit about that sense of even how a team could come together to try to figure out even how to advocate for going forward, and then just a little bit more about that communicating respect to patients who are limited in the treatment they can achieve or they can receive at this particular moment.
Yeah, fantastic. So, I think part of the first side of your question might be this idea of moral spaces. Like, I think that what happens in just like the everyday business, but also maybe in urgent situations, is that we're very pragmatic. We're thinking about like, the tasks or the steps that we need to put into place. So one encouragement would be to think about setting aside time in discussions, to thinking about like, to centering it in the ethical reference points or the values. And then to think about a question like, well, how will this be experienced by, and actually asking the question of, those key partners or maybe some representatives of the people you serve, how are they experiencing particular circumstances? But definitely this idea of making moral spaces. And then demonstrating respect. I think it's already, respect is already demonstrated by some of these things about transparency, about attentiveness. Is part of it also something we could talk about in terms of virtuous action? So if I went back to Hugo Slim, he talked about kindness, and he talked about humility, I think was there. And if it wasn't, I'm going to add it in, like, how do we act with humility in this particular context? So those sort of dispositions, like what is our posture as we engage with people of, acknowledging what we don't know, or the uncertainties that we face, expressing why we've made certain decisions, acknowledging that people might disagree. The very idea of procedural fairness, one thing that might be helpful to emphasize there is that it's saying like reasonable people might disagree about the priorities that we set. That these are potentially contentious, or certainly they afford different angles of view. And what we're trying to do is to establish a process that people could all agree that it's a reasonable process, whatever the outcome. So even thinking about some of those notions about just being clear about why, about, you know, being open about expressing how we did it and what the decision was made, and saying like, we're going to receive feedback, and we're willing to change if we learn new things or the situation changes. That also might be helpful, of just thinking about procedural fairness and acknowledging that there might be different points of view of the decisions that could be made.
Thank you. Really helpful. And a quick observation from Chennai is just that this, you know, in some senses, no matter what our context is, the pandemic has had an effect, a similar effect of exposing vulnerability and making the vulnerable even more vulnerable. And so that, you know, just that note is not just developing countries or low-income countries that are experiencing this, that we're experiencing this in Canada, for example.
100%. So I absolutely resist the idea that it is an equalizer from the perspective of saying like it's affecting everybody in society the same. But there are other ways that it is, you know, it's a common experience. You know, someone said that we're all in the same storm. We're just not necessarily in the same boat. So, you know, countries are in different places, and then even within countries, for the inequality is aggravated everywhere. So people within countries are experiencing it differently. And obviously it's very regional, like it's epidemics within a pandemic, right? So Montreal is very different than Toronto, is very different than other parts of Canada. Chennai is probably different than other parts of India. So that recognition of what we're experiencing that's similar, and then also the great difference and the way in which we're seeing an amplification or an aggravation of vulnerability. All that is very true. So great observation to finish on.
Thank you, Matthew. This is wonderful. You know, the time has flown by. I think there's a lot more to discuss, but I want to keep the faith here of saying we start and end more or less on time. Just very quickly, you know, there is so much left to discuss. Niti posted that we will have all these resources that Dr. Hunt has mentioned posted there for your review. We'll be updating the COCP website. If you haven't checked it out, it's got a new look. It's much more user-friendly. Please do check it out. You'll see some more on this, including, you know, some offers on Slack from our last presenter, Marina Capodonico, about talking a little bit more about pre-surgical cleft care and thinking about how that affects as we gear back up. You know, what does that mean for vulnerability, for respect, for these topics we've talked about today? So coming up, again, another element of that advocacy that you're doing, or discussions you could be doing, is around economic evaluations of quality of life. And I love, you know, going back to the beginning of Matthew's discussion about, you know, what does good life look like for families affected by cleft lip and palate right now? You know, that is something to keep in mind as we discern and discuss and negotiate and plan for what's coming next. And I think I'm particularly excited about that checklist that Matthew didn't go through in detail, but I think we'll have some more discussion about that, how that could be helpful for our internal discussions, as well as our discussions with our hospitals, with our ministries of health, with our country, in terms of what this looks like, what care looks like for families affected by cleft moving through this COVID-19 era. So thank you again to Dr. Hunt. I'm really grateful for bringing this outside but inside perspective of how rehabilitation works. Thank you for joining us today on this call. We will have more discussion coming shortly, including 2 more webinars in May, and we'd love to hear your feedback at any time. Feel free to send us an email at info@cleftcircle.org, and we'll be sure to get in touch. Thanks so much, everybody, and thanks again to Dr. Hunt.
Thank you very much for the invitation. Take care, everybody.